techniques like flipped classroom for teaching and so many newer the 360-degree global evaluation or assessment of a candidate, and all those techniques that have come in now, which we can find in all the sites of ICU or ophthalmology foundation. We need to incorporate those in the newer curriculum we build, and look at the best curricula across the world to adopt the best aspects of those which are fitting in with our teaching milieu. And we once we do that, then there's no reason why we can't, as a team, work on NMC and national board to adopt those curricula. And I'm sure we have enough contacts and clout to be able to do that. Hello. Hello.
So thank you very much, sir. I think in this year, I would really like to implement whatever you have said. And I think, yes, sir. Can you hear us, sir?
Yes.
Grover,
I'm
sir?
Yes, I can.
I think
And it's
it's,
wonderful that you're taking it up.
yeah.
There is a lag,
Yes,
it's
sir. The connection is a little poor.
it seems that,
So
yeah,
thank,
the lag,
yes, sir. Yes, sir.
yeah.
So I think this year, let us do it in a time frame, and let us do the advocacy also and persist on it so that the NMC can take up this curriculum, which has been excellent. With a little more changes, I think we can really do it. Thank you, sir.
Thank you. Thank you very much. Thank you, Santosh. Thank you, Partho. Thank you.
One question from Asha.
Yeah.
Very nicely put, sir. So I teach in a DNB institute. So what I would, two of my suggestions. So just like publication is mandatory for MS, there's no such compulsion on the DNB students. I think we can take that up so that they are made to publish before, so that they need to pass. There's no such compulsion on them. There's one point, and the other thing is what I have noticed sometimes when we are asked to go through the thesis, especially for MS students, the copy paste has not stopped. So if I was trying to start it in Orissa, suppose we could have a pool of thesis topics, like we specify the thesis topics and we give the criteria that need to be met. So each student can take up a thesis topic from that common pool if he or she desires, the ones that can be done at their institute, because sometimes they lack ideas and then they resort to all this copy paste. It's not that all of them don't have the will to do it, it's just that they need a little guidance. So if there's a common thesis pool with the mandatory things required for that thesis, maybe they can pick up ideas from that. We could have a thesis pool which can be collected by students from
I
every.
think very good point. I think Dr. Partho is here only. I think we should have AI was also helping the teaching part in our various institutions, and we can make ARC the segment responsible for this area also. They are doing good job. They are going across the country, district level also, but they should help in this direction, and getting the research is one important part. Academic help, which is secondary important part. Third is helping the young generation coming up in an institution where things are not sufficient also. I think ARC should be a part of making student come up in all sectors. And thesis is one very difficult area for these people who are doing fellowship programs or MD, MS or DNP. So we should help in those areas. We can make, as you rightly said, we can have a pool of thesis topics, and those institutions where they are going to do that thesis, because idea will be somebody else. So at that, responsible by the institution or a guide to give a credit to that person also who gave that topic also. And to complete that topic, AI should have a fund to support that student also. I think that will be our, in fact, my agenda also, to have some fund to help the younger student to come up with these research ideas, support them, initiate them, or give a monetary support also. We'll do that. Partho?
Thank you, sir. Yes. Absolutely.
I think that's a good thing that you was talking about thesis topic and publications. But publications has two limitations. One is the resource setting of that particular institute, and how many of the teachers are publishing. We cannot expect a MS student in the first year coming from MBBS to select a topic and then make it publish unless and until the guide or the faculty in that institute are not publishing. Even in an institute where some of the faculties are publishing regularly, they are able to guide the students better. Their theses are getting published, and those faculty who, because they are faculties and they have to guide a thesis because of the process and the system, it doesn't work that way. So until and unless the faculty is publishing, we cannot expect that the students would de novo have that idea to publish, because publishing is nowadays not easy, especially in a non-predatory journal.
I think, a lot of thoughts have come up. So we have our editor IGO, we have Chairman ARC, and all of us get together and make this possible. I think it's absolutely doable. We'll do it this year itself. Santosh. Okay. So Dr. Purvi Bhagat, you've been waiting patiently, and we've been waiting patiently for you to give your talk. So Purvi, we wish that you were here. You're one of the very, very vibrant teachers, and we have seen you in the times of the ICO training. You remember, Purvi?
Yes,
the
sir.
ICO training that
Yes,
you
yes.
took when during my ARC chairmanship time. So Purvi is one person who got trained by the ICO training module, and she could emulate this training in different parts of the country during that time. So we'll have Dr. Purvi, please.
Thank you, sir. It's my pleasure to be part of this forum, and I really apologize that I cannot be personally there amidst all of you stalwarts because of some personal reasons. So I'll be talking on innovations in teaching. So the first question that would arise in everybody's mind is, why do we need innovations in teaching? We all have been teaching since so many years. Now suddenly, why do we need to change or innovate? Because there are certain limitations of conventional teaching methods which we have been following since so many years. The most important being that there is a very heavy reliance on passive learning, just a lecture delivery with a lot of text in the PowerPoints, and the focus being on memorization and less on comprehension and retention. Because of this, there is a limited student engagement and interactivity. And also we sometimes fail to understand that as since we just discussed about this in Dr. Sharma sir's talk, that we fail to understand that different students have different learning paces and styles. When we deliver a lecture for the student, it is like drinking from a fire hydrant with a straw. There is a lot of bombardment of information within that 30 or 40 or 60 minutes of talk, and the students are simply not able to absorb all that information that is coming on to them. It's a one-way flow of information. The faculty comes, plugs themselves into the PowerPoint, plays, and leaves. Much of the material is also based on just notes, presentations, and textbooks, and much of the emphasis is on theory and lesser on practical and real-life situations. And the focus is on how to clear your DNB, how to clear your MS or diploma, rather than actually focusing on the results. The students, if we see today, they are also very techno savvy. They have a lot of distractions. They want to learn from different types of formats and not just one type of a format. And they have a lot of other commitments, distractions, and other limitations and expectations. We also need to train them for different contents. We need to give them formal training. We need to teach them informally, teach them the basic sciences, teach them advanced ophthalmology and career-oriented training also. We also need to focus on different domains. We need to address the cognitive domain that deals with the head. We need to address the psychomotor domain, which deals with the hand. And we also need to address the affective domain, which deals with the heart and the feelings and emotions. For the students all around, there is an academic marketplace. There is so much of information, so many resources available. Why would they want to come and learn from you? Furthermore, there is a limited time to learn, whether you consider it 7 to 7 or 9 to 5 or 8 to 8, whatever, and a 3 year or a 2 year training period. So we need to teach them and they need to learn in the most efficient and effective way possible. And therefore, there is a need for innovative teaching. We need to be creative. We need to think out of the box, do something different than what we have been doing, so that it's a more student centric teaching that happens. So I'll just be discussing a few of the options. There are immense number of options and innovations available which you can try, but these are just a few which are very easily replicable. So rather than having those exhaustive and elongated lectures of 30, 40, 60 minutes, we can have micro lectures or mini lectures, something more like TED Talks. We just deliver bite-sized nuggets of digestible information, which the students can attend to, remain focused on, and have the retention of concepts, rather than having a huge amount of information, the whole of cataract or the whole of cornea or the whole of angle closure glaucoma content being delivered in a limited amount of time. Videos play a very, very important role in education. And when I talk of videos, it's not only surgical videos, but it could be videos about skills, videos about how to take vision, it could be videos of how to do digital tonometry. So all these, and there are lots of ready-made videos available we could create on our own also. And cinema education also has a very important role to play in today's teaching and training, especially when we talk of affective domain. So all these are just a small list that is there. There is a list of Bollywood movies that we can use, clips from Hollywood movies. So these not only engage the students, but they also very well bring about the impact and content delivery that we are expecting. Storytelling is also very, very important. You can tell stories about different patients that you have treated. Patients' videos can be made a part of your presentation, or even patients can be brought into the clinic or that lecture area or that seminar room, wherever, and they can tell their own stories. So this helps the students to engage better, and they help to relate better about what content is being discussed. Whenever we have challenging cases in the OPDs, rather than we going and doing the research and bringing solutions, we can ask the students to do the brainstorming, so that they can come up with creative ideas, do some out of the box thinking, and do some problem solving. And then that can be taken up the next day or maybe a couple of days later about how to deal that case. Flipped classroom also is very, very effective. So the usual conventional way of teaching is when we take a lecture, and after that we ask the students to go back and read or maybe do some assignment, or just refer back after a day or two. Rather than that, the first step would be they go, they read, they have some prepare some material, and jot down their doubts or queries. And then when in the session we meet, we either do doubt solving, or maybe we emphasize on the core components, or maybe we address and take one step ahead and teach the advanced aspects of those teaching. So the primary learning would be from their end prior to the actual session, and in the session only some emphasis on some core components or other aspects is done. We can also design learning management systems. These are very, very popular, especially since the COVID area. They have been very commonly used, especially for UG teaching. So we have Canva, we have Moodle, we have Google Classroom, which is very, very popular. So this is a primitive one which has been designed by me. So either a single faculty can design it, a group of faculty can come along and design one LMS, or it can be done at the institutional level. So herein you can put in all your resources, the content, the videos which you think are important for the students. You can put up assignments, you can put up quizzes, and you can also check how they are progressing over time, what they have done and what they have not done. In the OPD, sometimes we have interesting cases which we see, and we just ask the students to, okay, go and see the slit lamp of this and tell me your findings, and something like that, which is a little unstructured. So in those cases where you have something interesting to discuss on, or you feel the students need some focus, you can follow the model of the 1 minute preceptor, wherein the students, they present their primary case in maybe say 5 to 6 minutes. Then a period of questioning occurs, why did you think so, what did you see, what is your further plan of management, and so on. And then the core discussion wherein you give your inputs. Okay, this is what you should have done, next time you do this, and after this you go and read this. This is going to be your next step ahead, and this is going to be your next objective. So we can do the same amount of teaching, the same content, but in a more structured manner, which actually involves the students more actively. Of course, large group teaching is common when we take lectures and other things, but small group discussions are also very effective, where you can give topics to them and they can prepare. And peer assisted learning is also very important, wherein our role is mainly to facilitate. The primary learning is done by the students themselves, so they can sit in pairs, they can think individually, then they discuss with their partner, and then they share with the large group and with the facilitator. Or it can be a jigsaw type, where more students get involved in more complex or large topics, wherein initially all of them are given some topics, then the group breaks down, they intermingle, they discuss those different topics among themselves, and then they come back to their home group and discuss what they have learned. So this peer assisted learning is also very, very effective. Rather than having sessions which are topic based, we can have case based learning, as was discussed in the first talk. So we can have cases and scenarios as the trigger problems, and then the talk or that session can happen based on this. For example, we can have a case of anterior segment, and then we can pose questions on which the students can discuss. We can have neuro-ophthalmology, posterior segment, anything. So rather than having a topic for discussion, we can have cases for discussion, which makes it more relatable. Talking of technology, today's the students simply love when technology is involved in the presentations. So we can have different types of games incorporated in the sessions, which are actually guarantee increased participation, learning, and engagement. And just to mention, Educa Play is one such platform which has different types of games which you can use for educational purposes. So you can use word games, you can use quizzes, you can build up different levels of problem solving challenges, which are known as escape rooms. It's more like a treasure hunt where you put in different clues, and as the students keep on solving those clues, they progress up and finally reach to the conclusion. So this is also a very, very important thing that is coming up nowadays in education. Complex topics or large topics can be displayed or shared as visual images. So either we can design these mind maps or concept maps for the students to help them to learn better, retain better, or we can ask the students to design their own mind maps and concept maps. So this is something about primary angle closure disease, a mind map which has all the information about what the criteria for classification, how you should follow up. And this is a mind map about post-operative complications of trabeculectomy. So that huge amount of information is given in just one simple visual image, which is very easy and interesting for the students to learn. Talking of the affective domain, role plays, they play a very, very important role. So when you talk of communication skills, professionalism, ethics, empathy, a scripted role plays either done by the faculty or done by the students, they are very, very effective in bringing the message across. Similarly, creative arts and literature, you can give them poems to interpret, express, and discuss on. You can give them literature. You can give paintings, or you can ask them to draw paintings and then discuss on that. And you'll be amazed at the type of expression and learning they can imbibe from such pieces of arts and literature. Narrative writing is also very important. You can ask them to write stories about what they have felt, their experiences with some patients, some encounters they have had, and reflections on what they have learned. So this takes the learning to a much more deeper level than the superficial cognitive learning that we all tend to focus on. Social media, of course, nowadays very, very popular. So we can have WhatsApp groups which are purely for academic purposes. Because sometimes in large institutes, what happens that the students, some of them in one clinic, they might have seen a patient, which is very, very interesting. But the students in another clinic, they might not have seen the patient. So those cases can be shared in the WhatsApp groups, and then discussions can happen. You can ask questions, and thereby try to cover up one topic or bring in some collaboration. Nowadays, Instagram is very, very popular. So the students can be asked to prepare reels on different topics, which will help them in learning also. Like maybe risk factors for glaucoma are there, types of IOLs to be selected. How do you decide on a type of IOL, whether you should go for a refractive surgery, any type of a topic which will be helpful for public awareness also, and that adds to the learning component of the student also. And of course, simulation based training, it could be something very, very basic and raw, like doing on fruits and vegetables, or something more sophisticated, high end, like the simulator based training. And of course, AI is now there everywhere where we talk about teaching education. So a lot of tools are there which can be used for training and teaching. You yourself, when you want to design maybe cases, or you want to think of what innovative method should I use, you can use a chat GPT or any of the other Gen AI, and you can use the inputs coming from there. And it also helps in personalized education. The students can be encouraged to use AI in different ways, more ethically and more in a structured manner, so that they feel that yes, the teacher is also contemporary, the teacher is also modern, like us, and they'll be more engaged with you in the learning. So technology definitely will not replace teachers, but those who use technology effectively will definitely replace those teachers who don't. And unless we need change our own learning, we cannot adjust and we cannot teach the next generation. So we need to be innovative, and we need to adapt to the changing situations of education and the learners as well. Thank you.
Thank you very much, Purvi. I think that was a mind-boggling lecture by you. Wish you were here in person amongst all of us. Uh, Again, one question to you, and
Yes, sir.
I think it's a very pertinent question. The curriculum for teacher upgradations, I think, is something that is still lacking in our systems. So here, we have very seasoned teachers like Professor Tityal, Dr. J. Biswas, Professor Pradeep Sharma, all very, very seasoned teachers. But I think, if I can be honest, we also need to incorporate the newer modalities of the teaching in our curriculum. So how can we go about that? So I'll ask JB sir. What is your idea, sir?
I think in the process of learning, or that preparation, like for a preparation of thesis or preparation of a seminar, the teacher should be actively involved. He would select the articles, he would try to find out, and he himself need to read. And you ask them to read that one and then come back. Not that. You himself should read, make a kind of almost like a small task work, and learn along with the student. Need to update your thoughts.
So curriculum for teachers, sir, what do you think? The government has curriculum for teachers, but most hospitals do not have. And these curriculum, I don't think, are taken as seriously as they should be.
I think, with the changing time, things are changing rapidly. And the perception of teaching also has changed so much. As Partha rightly talked about, there has to be some sort of program or institutional accreditation programs where teachers can also be updated to a newer way to update themselves in various aspects of teaching. I think that we don't have in India. So that has to be there. Then, what is the regulatory things?
Education sector, you have anything to consider. If you are doing it wonderful. We have all these teaching programs like Fiber, like me and Ruby, we've been to this fellowship of advancement in medical education research, and a lot of things have been drafted and it's been mandatory. And I feel that with the competency-based medical education into the drafting of NMC, we've been doing a lot in medical college.
I think that competency base has to come, and it is still to be placed for people to be there, and which will be something, maybe a better way to look into aspects. I give you one example, like, people, the teachers, you have initial programs, but people get promoted to a various stages from assistant professor to associate additional professors. But nothing like that, okay, you have this competency, that's why you become a professor. So one basic guideline people talk about is what has been your contribution in teaching, research, and patient care areas. So patient care is the least important for promotion areas. Your research may be a more important aspect. How many publications you have, how many external projects you have, how much your funding you have got for the institutions, and effectivity of that. But teaching part is lacked in our scheme also, promotion schemes. We don't really ask whatever teaching you have done for your promotion in those period of which is considered for promotion. Publication may not be teaching, or just number of hours also is not a teaching. We write, okay, how many hours you spend for teaching? I write, okay, 4 hours in a week, or 1 hour a week for undergraduation, and 6 or 8 hours with the post graduation, something like that. But there has to be some specific objective point for that, as you are trying to say, which may be important. It's structured program.
Structured program. I'll ask Girish.
Can I, sir?
Yeah, Purvi. Yeah.
Sir, yeah. So I just wanted to add that there is a mandatory regulatory requirement by the NMC that compels all the medical teachers to undergo some basic training, wherein all these upcoming and necessary teaching, training, and assessment methods are being taught. So that is a mandatory requirement. Unfortunately, what happens is most of the medical teachers do it just for certification purposes, just because it's a mandatory requirement. It is actually then not, taken back into practice. So that thought process needs to be changed. Of course, there are more high-end medical education courses which people can do if they are interested in. And third is just like the students are accountable. They have now the PG logbooks are there, the UG logbooks are there, wherein they write all that they have done, the reflections, narratives, everything is now documented. So if something more accountable is done for the teachers also, and even abroad, if we see there is a feedback given by the students at the end of the session for the teachers, the rating is given, the feedback is given. So if something of that sort can be adopted, there is a lot of resistance against this. But if a teacher's rubric can also be practiced, then perhaps it might change the scenario to a great extent.
Okay, Purvi, big
May I say
thoughts,
something,
but I'm going
Prato?
to. Yes, sir. Yes.
There are two aspects. One is that, as Purvi said, we have now excellent material available. Ophthalmology Foundation has 15 very comprehensive, very well designed modules in the newer techniques of teaching. And they've been very well illustrated, very well spoken about with videos, with everything. So those can be used by anybody at his leisure. That is one aspect. Second is the teaching should be a very important part of promotion, as Jeevan said, but that can only happen once there is a evaluation method for how somebody is teaching, not just the hours, but how well he is teaching. Now, unless we introduce the 360-degree evaluation for teachers, as Puvi was saying, there can be no way of putting that in a quantifiable form, which can be taken into consideration for promotion. So I think that has to come in. So this assessment part of teaching, just as we assess all the other things, just as we evaluate a resident or a fellow, we need to have the assessment for teachers. It will take a lot
Absolutely,
of
sir.
resistance,
So
but it
we'll
will
go
happen.
to Girish now, sir. And Dr. Girish is the head of Shanganitralaya, and you have a very, very vibrant teaching program. Do you assess your teachers? Do you upgrade your teachers? What are the incentives? Do you have a rubrics for your teachers?
So we are in the process of coming out with a rubrics for teacher assessment by the students. So as we said that we have a lot of one-way assessment of the students by the teachers, but not the reverse way. Then of late, what we have found out is when the students do have these exit interviews, they do give a very frank opinion about the teachers. And then we found out that there is a huge gap between some of the top performers and they're not so top performers. So now we are incorporating an anonymized way of the student giving a feedback about the faculty at the end of the month. And this is then collated, and then during our consultant meetings, we try and discuss on this and try and come out with answers to address these issues. We try to incentivize the teaching programs for the consultants. They are given academic offs. They are promoted to go to international conferences or other meetings based on their time that they put. We have a system where the promotions and any other incentives are equated across research, clinics, and teaching. So in a way, I know it's a difficult balancing act to do, because people who are pure clinicians feel that they are more productive to the organization. But I think if the institute understands that academics and research is also equally important for the long-term sustenance of the institution, that's where the focus will be.
Thank you. Yeah, Samrat.
So when I was doing my fellowship in 2000, 2001 in LBPI, they started this assessment or feedback from the fellows to the teachers. I think Dr. Santosh should remember. And it did bring a change in the, the way that things were taught and how things were done. So, but then I know it's a thing that most of us would resist, and we have not been able to implement it in our institute. But I think that's a way forward, if an anonymized and non-victimized way, if that can be done, because it's a double-edged sword, so it can go either way. Right. And the other thing is that the NB doesn't have a system of actually giving any kind of designation to the teachers. We are all there as a consultant, so there is no system of professor. So all those things are there.
I think, very important points have come up from this discussion after Purvi's talk. And I think curriculum has to be set for assessment by the students of the teachers. And a very small step that can be taken immediately is what we follow in our very small center is we have an anonymous box. We call it AB, that's the anonymous box. And after any lecture, even a lecture by me, the anonymous box goes to everybody. Small chits of papers are there. Grade of 1 to 10, how much have you graded this lecture? So it is 8, 9, 10, 5, 4, 3, 2. There will be always 1, 1, and 2, but it's the average that makes it, and you have an immediate assessment of how you have taught or how you have related to your students, how much they have understood, how much they have liked the lecture, how much you have ignited in that 1 hour of lecture. So I think these small steps can be innovative ways in which you can get a feedback. iFocus has an excellent way of getting feedback, and a golden apple that is a very, very prized aspect. In fact, when I prepare my lecture for iFocus, I take very special pains that my lecture should be better than Dr. Gandhi's lecture. Tetial, sir. Yes. So Professor Tetial is here, and again, great. Given the 7-minute, 8-minute presentations he makes. What goes behind the is what makes the practice. And Sir has been a very, very meticulous surgeon throughout his life, and I think anyone who has seen him doing surgeries would understand how meticulous, how wonderful not only a teacher, but a surgeon he is. Laptop is getting ready. I'll just tell you very quickly, Dr. Tetial's surgery, one of his first surgeries, I asked him to do a live surgery in a very small township of Rajgiri. Rajgiri is in Bihar, in Nalanda district. And sir came all track to him as 25 years from today. And sir, we had asked her to bring his own instruments because we knew that our instrument sets were not at us. That was a great, great shock for us. So all our technicians quickly made use of the skills of brushing up the instruments, cleaning the instruments, getting them autoclaved and everything. And then ultimately when sir was handed the instruments,
I'll do this, this will be my step. And that is the good way of thinking and executing that, And the planning should be in such a manner, you see your patient, then think what type of surgery, what instrumentation, what equipment you're going to have in this. And this learning curve is, there, therefore the practice has to be there, surgical training has to be there in these cases. And absolutely mastering each step of surgery will ultimately complete your skill to give to the patient. The important thing is to see the outcome. Patient doesn't realize who done the surgery. It is important next day what patient sees, So we have done a beautiful surgery, you think, but sometimes patient may have 612 vision because of something else would have gone wrong. So surgery is not, from our side, we have done the surgery. From patient point of view, it is the outcome only. So that will only come by good coordination later. Just going there.
Yeah.
So therefore, we need to have a good, foot coordination for doing surgeries. Concept we talked about, the cognitive memory, muscle memory, simulation nowadays is a major area for training to improve your outcomes, and subsequently actually doing live surgery for these patients also. So basically, we have procedure of a supervised areas. This supervision of operation theater area, I think that is the first thing, when I joined RP Center, to get into operation theater floor was a challenge. I didn't know how to enter that floor because you have a mind, it will be very, sterile area, how to walk in, where is the changing room, what is going to happen. That is a sometimes challenge for our students also. So there is not only the faculty who's going to give you that idea, how to enter, how to do all those things. It will be the nurse or the staff is in charge of that area, or people who are there who tell, okay, this is a changing room, this is your wash scrub room, and this is the OT, how you have to enter, where you have to change your slippers, which is the just open area, which is a semi-sterile area, and which is a totally sterile area. And that experience should be given to a beginners as such. Then our discussion we had on a continuous education, which is important for our surgical training also, especially going through the workshops, video-assisted training systems, which have been a part of various conferences. That should be part in the teaching also. Now we have a lot of social media. We can see various videos, which will be a very, very interactive in terms of going through that. But only thing missing is you can't interact with the surgeon there. You have to put a question, subsequently the answer will come later. So that is one-sided teaching for us. Simulation and wet lab training is a part, which is benefit is, you can train with confidence without, thinking of consequences. But ultimately, all this should translate to the surgery which they're going to do on operation theater to the patient. So basically, we are going to train them for actual life surgery to be done in these cases also. Briefly, I'll take into two aspects. I think Dr. Tushar is going to talk about how to train in the wet lab conditions. So simulation is, we all know, is going to be beneficial without any risk to the patient. And that also gives the confidence I'm not going to damage anything, which we already had when we started. We didn't have a simulator, so wet lab also. So we had apprehension when we went for first case. The first thing came into my mind was, I'm not competent, maybe I can damage the eye also. That inhibition has to be taken off from our students. So we had in the RP Center the IC system for a very, very long time. We have now various other systems coming up, which will also decrease the financial burden to institutions also. And this surgery can be very, very effective sometimes, can be done with especially the feedback mechanism, which can be given directly verbal, or subsequently it can be feedback in a database also. That is very important, which patient doesn't tell you during the surgery, but this system will tell you are going wrong, what mistake you have done, how do you have to improve, and that is very important for people to understand. These are 6 important things which we like to do in our training in a simulation. Enhance your skill acquisition, that is by accelerating your learning curve, because that is going to be important, because as soon as the one beginner joins, he or she wants to do live surgery as soon as possible. They don't want to wait for one day also. So that is one challenge we are facing, to give them a skill as soon as possible, give them the idea of patient safety, and do a standardized technique which we all have now, adaptability and AI-based systems, which is going to make things more simpler for a future training also. In wet lab training, I think this gives a much more better than simulation, because you have actual table where you have the position, hand position can be there. You can position your neck position, seeing through the binocular aspect of a microscope. Then that gives you hand-eye coordination, foot coordination also, because actually you are playing with the phaco machine there. So dexterity will be very, very important, and basic steps first, advanced procedures, then complication management can all be done in wet lab conditions. And it can be done with goat's eyes or any animal eye. And nowadays we have the various other synthetic eyes also, which are available and can be important also. The wet lab facilities should be very, very lucrative, because people should be able to enter there, have a feeling that they are in a better place, and your teacher should be there to give them a steps also. The best teacher would not be your professor or a senior most consultant, maybe your own colleague, which can give you a basic ideas of doing surgical steps in these cases also. I think it is important to have any institution where postgraduate teaching is happening, wet lab system has to be there in those cases also. In fact, you can do any type of surgery, wet lab condition, right from the conjunctival autograph to squint surgery to retina surgery also. And that's really going to be helpful for our people also. The better part is to, once person goes through these simulation and wet lab training, is to prepare them for an actual live surgery. That is a step-by-step approach for a student to get into that. The first thing which we like them to know is how to prepare your patient pre-op, before the surgical patient is in surgical table, preparation of instrument trolley, which is a very important aspect. Sometimes students they don't know what all instruments are required, which are the regular mandatory, and which are the accessory instrument that has to be there. Get acquainted to the machine, how the basics of machine, how does it work, and what are various parameters for both for our operating microscope as well as the phaco machine which they have. Sorry for a spelling mistake there, and the vitreoretina machines also. Then assist the surgeon, your mentor, then actually get assisted, then do a stepwise surgeries, then actually do surgery yourself, get your surgery reviewed. And these are what we like to have, assisting the trainer, which is very important part. Because when we were students, we didn't have the microscope where you could see through the side view. So sometimes we used to observe from the side. And whatever teacher tells you, you have to say, okay, I can see, but you're actually not seeing anything in those cases. Then subsequently, we have a monocular view. So you didn't have the binocular view for a side tube. Then subsequently, you had a binocular view, and that also improved. Initially, you had the a split, then you have a full view from what surgeon is seeing, and that is how things improve. And the best part of assisting the person is should be active assistant. Sometimes your students are not active at all. They feel they have been harassed by sitting with a surgeon. The surgeon doing, I'm not doing anything. They'll just through the saline of the eye like this, without knowing that where they are doing. The best assistant is he or she will observe what are the various hand movements, the physical movement of person, how the patient is being handled in a difficult situation also. So I always say, just don't see what is happening, see what he or she is doing as a trainer. That is very, very important for us to know. So this is what I used to do when I initiated my student in the beginning, because this is 90s and early 2000. So I knew how to make a person comfortable for initiation. So in RP center, we used to first, we still do it. We give an initiation extracapsular surgery, then phaco, then later SICS if they want to get through that also. This because I think one of the most important part for developing the stereo acuity and getting the depth perception is suturing. If somebody can do a good suturing, then he or she is a good surgeon. This is one criteria I take for any person doing surgery. I've seen, in the beginners, sometimes just to put a 5 suture, they might take 1 hour also, because very to do suturing. They require both hands to be properly done. They break the suture, they put loose suture, tight suture, irregular suture. And that is one criteria I've taken in my initial times. If student can do a good suturing, he or she can be a very good, surgeon. I remember when Dr. Pradeep Sharma talked about, in our days, you used to do ICC. A patient used to be there in the ward for sometime more than a week. And there'll be 2 rounds at least by a professor. I remember my Professor Sood, he says, observe this patient, see the suturing. He'll say only to see the suturing of this patient. So that effectively gives how radial, how equidistance. That was the criteria for this thing. But for a phaco training, what I should do a reverse initiation of phacoemulsification for students, so that he or she doesn't get, lose their confidence when I'm giving my cases to that student to complete. So I have to go first, give us some IOL implantation, because they'll say I've done something. Then initiate them for irrigation aspiration. They are safe procedures. And third important part would be I have to do a nucleus chopping, keep the pieces there. He or she has to just eat the pieces. And that immediately gives the confidence I can do phaco now. Then shift to a nucleus trenching, divide, and then see how he or she is doing. Sometimes, trenching requires a good depth perception. And these people struggle. I've seen they're just playing in a superficially because they don't know how deep they have to go. And trenching also tells you what should be your phaco parameters, and that can be judged to them. And subsequently give a capsulorhexis, hydro procedure, then towards an incision. So, thinking to a young person how he or she can complete the surgeries, then subsequently complete the entire surgery by this thing. But all these things have changed now because you have this standardized way to train this. We have very structured, development surgical areas, PDP, like a phaco development programs, where everything is very structured, accredited. You have to get into competency phase before you shift to a surgery. In surgery also, we have a specific trainer who he or she will record the cases, assist that person, and discuss subsequently also. But this way, you can make this person very, very effectively. So basically, it is important to build the confidence of your student, or for yourself also. You are graduating in a new surgical area, and you should be able to take up the difficult cases also. That means if there's some complication, you should be able to manage the complication. And complication in any surgery, I think stress is one of the most important areas. So if you can manage the stress of yours for a normal surgery, or once you have a difficult situation, then you become a good surgeon or master surgeon, because it is the actual challenge for us to manage that case properly. That's why people they like life surgeries. They want to know how this person handles the stress of a life surgery. Otherwise, what is there in life surgery? You are doing a routine surgery, but we are sitting in the audience just to see how does this person takes away the stress of life surgery, especially has a difficulty or complications. Because I know that people, shift to other surgery as soon as they have a complication. But you ask the audience, they'll say, no, keep that surgery going on. We want to see how the complication being managed. So that is what we want to build a confidence to our student to that area. And that will only come by doing more and more surgeries, regularly practicing them, and you ultimately graduate into better surgery. So this is what we talk about, the real-time teaching the operation theater. I think that this is a new device. I think future, all operation theaters should have this, large screen, which you can have a 3D appearance, where the student can see what is actually happening, what the surgeon is seeing in the 3D effect, and will be a good tool for surgery for future also. Then we get, discussion happening in our wet lab area, whether each surgery is recorded by or PDP person of students, and discuss those videos in a group, so that all the hesitation are come off. You can show your own video, you can show the students' video also, and discussion, and that will improve their caliber also. And lectures, conference, a good part of teaching. I think the most important part we talked about is objective structured assessment of our students and the teachers also. recording your videos, and the logbook. I think surgical logbook is also very important. Nowadays, it would be compulsory if you can record your cases and you have a, your library of surgical videos also. In fact, I was from my office recently when I shifted my office. I saw I had almost 200 VHS videos, and they are now useless. And I had almost those you can say floppies, hundreds of them. And now I have a digital recordings, which maybe I don't know how many terabytes. I had a full box of those videos. They are basically my treasure. And I'll be seeing those videos again and again. And that is very important part. Recording your whatever you have done, and that is what is going to make a difference. I remember my one student, Dr. Panam More, who's in Pune now. He was my thesis candidate. So whenever he meets me, he says, you are my teacher. Because he had evaluated all my videos because his thesis was these rollable lenses. He said he had learned seeing my videos only. So that is how things should be translating to your students, and they should do a important, subsequently they should be teachers. I think once you do a practice, you're going to have a, something coming up, which may be a new technique you might be able to develop. You can innovate various things, and that can happen also. So this is the innovation. We acquired the OCT microscopes. We could do a surgery in a different manner. You could see what is happening inside the, your surgical step also. We had the, entire scanning on the table. Type of white catheter can be seen. What happens with your, each step of your surgery. And that is an enhancement of your approach to surgery also. That will be based on your surgical acumen, based on the innovation which has come in our surgical instrumentation and devices. And that will give you a more innovative chance to see, to document, and to teach your future generation also. Therefore, I think to summarize, it has to be very structured surgical training, CME, wet lab, assisting human surgeries, listen to your student and your guide also, either way, then get them to do independent surgeries, observe, have a peer discussion. That is very important. Keep learning, which is very, very important for all of us. To make a good ophthalmologist, Dr. Sharma talked about this, a good clinician, good surgeon, skilled ones, be a good teacher, good a team player. I think that's the most important part. Dr. Sharma is sitting along with me in this OR room. And basically have a very empathic be a human being which has the, not only for yourself, you have the sympathy for your surroundings and your patients. Always build a surgical team. You can't learn your surgery yourself. It has to be team. If one person does something wrong or mistake, entire surgery goes off, and responsibility lies not only to surgeon, to entire team also. So if I enter my OR, it's because of these people who make things so simple. And I talked about stress, and stress goes down immediately if you have these people there. And it's very important, and they are indispensable for your OR areas. I think 3 P's are important for building your surgical skill, practice, have a patience, and have also persistence to develop your skills and get to new areas. And surgeon will remain surgeon, always till you have the end of your life, you remain surgeon. And if your body gives you feedback, you can do good surgery, you should keep doing surgery also. The last thing is, we have shifted from manual to capsular access to laser things. And this is what my manual CCC, and this is my laser CCC. They should look almost similar. And this should be a safe, predictable, repeatable to all type of challenging cases. Because phaco, people talk about only thing nucleotomy, but everything should be a practice in a regular manner. Make sure you have the outcome which is desired by every patient. And aim is to achieve long-term success. It's not today I have learned something, so that's the end. It's not never, because every time new challenges keep coming. Because today I'm doing surgery without looking through the oculars. tomorrow I'll be sitting in my office doing a robotic surgery from my office only, and maybe I can do surgery for US also sitting here. And that is what we're looking for, long-term success, which lasts the quality for patient for a long, long time. I think surgeon we are making by a structural institutional training. Good surgeon will be a person who practices and gains experience. Accomplished one, experienced surgeon can do all type of surgeries. He becomes teacher and mentor for others. And the master surgeon is one who everybody likes to follow them. And that should be our goal as a teacher, and make your student your own teachers. Thank you for coming.
Very much, sir. And thank you, Professor Azad, coming around, sir. We missed you in the first session.
He came at the right time.
So, sir, whatever you have said is phenomenal. It just gives me an insight to my fellowship days at Shaganitra, and I'm going to tell you a few things that I've learned there and some things that needs to be incorporated. I think, sir, the first and foremost thing that, as students, and these our school teachers have got us, the Kaak Cheshta, Vakodhyana, Swan Netra, Alpahari. So if that is possible for everyone to comprehend, Kaak Cheshta means like the crow you have to go on trying. Vakodhyana, like the fabula or the stork, you have to keep your concentration accurate. Swan Netra, just like a dog. The sleep should be just minimal and to whatever effect it has. And Alpahar, you don't want to, because that's our energies.
I think that's scary. You should not sleep during the surgery, both for you and your assistant also.
Yes.
I've heard this one conversation from one of the interested, and he banged onto the microscope like this, and the entire surgery went off.
So one thing that I think in the surgical curriculum is so important is discipline. Discipline of a resident becomes the most important factor to the surgery and the surgical outcome. As a resident, right from scrubbing to getting ready, to understanding what surgery he has to do and what is to be predicted and to be told to the patient and patient party at the end of the surgery. The whole gamut goes into one structure, and that a resident should learn from the teacher. And as teachers, if we can incorporate that, I think most of our effects are done. Beginning of even a simple surgery, or even if it is a very senior person, a trauma or traumatic cataract surgery, where a very meticulous planning should go in, same thing has to be incorporated to a resident while doing. So I think at Shanganitrale, as a fellow, we were watched as when we scrubbed, and there was a system and we all knew it. Our sister would be watching us scrubbing, and if a cut corner was there, a memo would come in. Same thing. The other thing is supervision during a surgery. And yesterday I was telling of a small anecdote I'm going to quickly share with you, is when I saw a list and I was allotted a surgery, and when I saw the list, my name was there, and supervisor, the name was there, Dr. S.S. Badrinath. I was kind of absolutely in shock because sir would be assisting me in my surgery. So with all the difficulty that I would have to be answerable, etc. So when I started off that surgery, I was there and scrubbed and everything. Well, everything was ready. And then Dr. Badrinath said, start. So I started and he handed over a set of instruments. And I stood up to receive those instruments. And every time he would hand over something, I would stand up. And then he said, PAB, when you are a surgeon, behave like a surgeon. So that again is a very important thing. When you are a surgeon, you have to take full responsibility of what you are doing. And that, I think, has to be ingrained into every resident, because you do well, you do a good step, you do a good correct surgery, the importance of it is going to come next day when the patient is going to actually get the optimal results. So I think everything goes in, and discipline is the cornerstone of a surgical training. Thank you. I think Dr. Kirti is there.
So I have a little other way of talking, like we are here giving the example of RP Center or Shankar Netralaya or LV Prasad. But we are not thinking about those institutions. Even the medical college, government is, they have never seen a phacoemulsification being done. Phaco machine is lying in the OT. Surgeon is operating in, teacher is operating with just with his glasses or loops, and students are learning. So if you see that total medical colleges and DNB institutions in the country, almost 1,500 postgraduate training, they are every year coming, and they're adding in our member lists also. But who will take care of these group of people? Beside, there are maybe 300 people in this group, 1,200 people on the other group. And who will teach those teachers? In spite of having microscope, in spite of having phaco machine, they are not doing phaco, they are just doing SICS or ECC. So that is, AIOS has to, I do not know, AIOS cannot poke their nose in individual state government level. And it is individual state government, probably RIO can have this role. AIMS, they can take lead to other RIOs. I do not know, but people, they do not listen. Government level, I am very much vocal, because government level, they do not listen to you. So it will be like we are talking, these are all super kind of teaching, but we have to come down to base level also. So we want to learn from the base level also.
No, I think what Samar is saying, I think he has a point. And in fact, what you are saying, about the government level, way back in, I think, year 2000, we had a program like training of trainers. There's something like this, GuruSangam. So that is possible only when you go and talk to the government. The other thing you said, it's not necessarily that we should approach the government. There are private medical colleges are there. I'll tell you something like National Academy of Medical Science. National Academy of Medical Science, they have a program of visiting professorship and also professor emeritus. So there, they are, like every year, they have in different specialty professor emeritus. And they are assigned to some medical college or some, some other teaching institutions where the faculty is there. And there, they go for, say, a week or so, train people, teach them, make them learn surgery also, and then they come back. So that is possible. If All India Ophthalmological Society, it takes the initiative, I think that is possible. You want to say something?
Thank you, Dr. Titiyal, for your nice lecture. Actually, I'm coming from Andhra Pradesh. So now the youngsters who are joining as assistant professors in medical college, they are already trained. They are already undergoing phacoemulsification training, and they are joining in medical colleges. So in AP, most of the youngsters, they were trained in retina and cornea, and especially phacoemulsification. And one more thing in teaching, most of the times the senior teacher won't train the junior most. So the assistants, they were less patient and most of the times if the complication arises, immediately they will take over and the junior surgeon or PG, he may not complete his surgery. So these things are happening. Actually, senior teachers, they need to sit with the junior most person and patient enough to teach them. Actually, my PG, I trained him even for phacoemulsification. So after MS, immediately he was absorbed into the one of the organization they took. So actually, it is the teacher who should have the thirst that I should make this child, he should do well. So whenever they remember us, definitely they will be great. We will have great feeling that we could train, and even student also feel very happy about us. He will remember those days. So teachers, they should not hesitate to teach the juniors. So in government medical colleges, usually the senior surgeon, he only do surgeries. He won't bring the assistants. So when we're in the medical college, in my medical college, actually all the assistants, I trained all the assistants, SRs, to do FACOs and everything. So we need to be broad mindset to train the juniors actually.
I think the point we talked about teaching day off for a person who teaching or research. You should have a faculty assigned for the teaching a student in OR also. That day, that teacher only teaches the student rather than doing his or her own cases. In that way, it will be more applicable. Otherwise, we are overburdened with our own cases of work. You hardly have a time to get to the student. And we always say, like, to assist, to assist. So in a way, we should have a program. It can be possible in institution, like you have a day, a rotation to the faculty. Okay, you have to, that is your teaching day in the OR.
Yeah, we have this in our institution. The other problem that she mentioned is that sometimes, like Dr. Prasad says, is no one is operating. The FACO machine is there because the HOD or the senior most professor, they don't do FACO, so they don't allow the others to do FACO. So these are sad part of the whole thing.
I think, we know these sad parts very, very well. Most of us have come from government medical colleges. We know how slit lamps used to be locked up and nobody would get. But we know the solution also to these problems. In my institution, during my post-graduation, slit lamp locked up. Nobody can go in. Very simple. You just have to give a thoda sa tip to the person who has the key will open. So, sir, कुछ भी दे दो सर, कुछ भी दे दो, चाबी खुलना है is the answer. So कैसे चाबी खुलना है, each one of us will have to know. So if a Centurion machine is lying and nobody is operating on a Centurion machine and the HOD will not, there has to be a way that Centurion machine has to be brought into play. So I think, the problems are there, the solutions are with us, and how we have to bring the solution is something very important. Yes. Santosh, I think we are cutting your lecture a little.
Sorry, just 2 minutes I'll take. I'm from JSS Mysuru. So we have assessment surgical skill as part of my advanced course in medical education. We did a project wherein these residents, when they were being performed surgeries, their peers would record their videos. And when they go back, they would rate their surgeries in ICO Oscar. So everyone was trained to read, and even the faculty were trained to read the ICO Oscar. Now they would give marks for their surgeries. And these recording would be seen by me and my other faculty members, and we would also give them marks. So the next day we would discuss at what points they went wrong. They thought some step they were correct. But then we assessed according to the ICO what was wrong in them. So and again they went back, and particular part of the surgeries they saw videos and again we saw that they really improved well. So we use this ICO Oscar for SICS as this one. And in fact, I did a project on this also, sir.
Yes.
So I come from Narayan Nethralaya, where we have this concept that, no, sir. So I have a slightly different take from that. I've been there for almost 13, 14 years now. From day one, the idea was no one should be barred from touching any machine, be it anything. Second thing is that if a new machine gets introduced to the system, be it anything for that matter, if it is an OCT or for that matter any topographer, the fellows, the PGs have to go there first and stand with the company people to understand how it's functioning. So that is something you should not be barred from. And the third thing is that you will not be penalized for having a complication. That is probably the three things that I've learned, and that is what I would like the students to get inculcated with from the very beginning. That fear has to come down. ये machine मैं नहीं छू सकता. ये rent हो जाएगा तो क्या होगा? So these are the things that probably we have to look at, sir.
Yes. So one thing what I think that the day one we should teach our student that cataract only is not the ophthalmology.
Oculoplasty is also
No, I am a UVA person, so I will say that we should ignite that flare. That cornea is equally important, that ocular oncology is there, glaucoma is there, plasty is there, retina is there. But even today we are discussing how to do cataract surgeries. How we should train our kids to be a good phacosurgeon. I think the day one we should teach them that this is MS ophthalmology or MD ophthalmology. This is not MS cataractology. That cataract is not the entire ophthalmology. I think that subspecialty, like I think that the good centers, the
Dr. Tomar. now the oculoplasty surgeon stands up.
What Dr. Tomar is saying, that is true, but partially true. I think to pass the MS or MD, after passing the thing, one must know how to do a cataract surgery. Must know, because National Program of Control of Blindness mein, cataract is still the leading cause of blindness. So that should be first taken care of. Oculoplasty, DCR and all, yes, they have already given the guideline. When you will do 50 cataract surgery, then 5 lacrimal surgery, 5 glaucoma. But cataract first. Without knowing the cataract, you cannot just pass.
where are those 5 traps and 5 DCRs?
Chalo, debate. Santosh, debate of teachers. So I think we'll learn from Santosh about the importance of tools in e-learning, and that's a very, very important subject.
Good morning. I'll be talking about internet resources in ophthalmology and how we can use these resources for teaching currently. It said that he who studies medicine without books sails in an uncharted sea, but he who studies medicine without patience does not go to the sea at all. But that's not true in the era of internet, where we know that learning and training are different from each other, learning being an individual effort, and it can occur anywhere, anytime. Sitting here, we are learning. Somebody sitting at home could also be learning, whereas training is participatory. So learning being at individual level, it is possible to learn using internet, and learning being a part of training, we can incorporate internet technologies into our learning very effectively. And knowledge can be acquired online, and we realize that, and that's how the world is currently, and we have to capitalize on that particular aspect if you want to augment our training. Internet has become inseparable from our lives. It provides seamless knowledge, but it's a double-edged sword because it's garbage in, garbage out. What we put in comes out. And good knowledge should be equivalent to good source. So we have to guide our students to go to good source of knowledge. It should be well moderated, reviewed source, preferably run by an organization of repute. So if I put in, say, neovascular glaucoma in Google search, we'll get a lot of information, possibly thousands and lakhs of pages of information, but that may not be well curated. It may be something which is random, which may not be readily usable. Whereas if you go to an individual or an internet portal which is run by an organization and use the same keyword, you'll get curated information, and that is what we have to use for learning. We have organized education portals which are meant for online teaching. We have journal websites, we have specialized search which is PubMed, and we also have ebooks. Possibly Ekalavya was the first documented e-learner because that's how we learned, isn't it? In fact, Shankanetralaya education portal was called Ekalavya. It is still called Ekalavya. So Ekalavya is the e-learner. Let's see how we can apply e-learning for diagnostic and clinical skills. We have a first year resident. He knows about refraction. You have taught him or her about the nuances of refraction. But then how does he know what a glow looks like before he goes to a patient? This is a simple retinoscopy simulator where we can change the power. This is available on AO website, and know the point of neutralization, how the glow changes. You can change the power and see how the glow changes. This is before the resident, first year resident goes to a patient, before he starts practicing retinoscopy. Similarly, how does a relative afferent pupillary defect look like, mild, moderate, and severe? It can be simulated online, and that can be learned. So when he goes to the patient, he'll be more confident as to what to expect in a pupillary reaction or what to expect in the retinoscopy glow before he starts assessing the patient. This is available. Earlier, it was on iontext.com, which was a website. Now it is on AO Interactive Tool Repository, Retinoscopy Simulator, and RAPD Simulator as well. This is also on AO Interactive. Now about gonioscopy. When you ask a first year resident to do gonioscopy, of course, you can view through the side view tube or a video, but then if you already have knowledge about various gonioscopes and how do gonioscopic appearance looks like, he'll be in a better position. Now about theoretical knowledge, we know about Wikipedia. For ophthalmology, it is iWiki. iWiki is a huge repository of information. It is classified alphabetically. You can see here in A, there are so many subtopics. This is actually built by the residents and fellows and curated by the faculty. If a particular aspect you think is suboptimally represented, you can ask your residents or yourself, you can update this information, and this is curated by a set of editors, and finally it will be published. So you can add on, it's a live book. It can be updated on a daily basis, weekly basis, monthly basis. And if a particular topic is missing, you can ask, you can supervise your resident to write it up. And the best topic, best written topic for a particular year gets a free entry to American Academy of Ophthalmology, fully paid. So it's run by AO again, iWiki, which is a very useful repository, curated up-to-date information. If you have a presentation coming up for a resident and on a topic which is not so common, exotic topic, and the pictures are missing, you don't want to take random pictures from textbooks or unacknowledged resources. So you can use Atlas of Ophthalmology, which is a good repository of all the pictures. This has good editors, and this is a copyright free. It can be used just with an acknowledgement to Atlas of Ophthalmology. Educational institutes run very useful training websites. This is University of Utah, which runs all these sub-modules in the website. Basic Ophthalmology Review, which includes ophthalmology-related anatomy, physiology, biochemistry, pharmacology, pathology, microbiology. And then we have optics modules, pediatric ophthalmology, orbit, and all the other subspecialties. In that, the subsections would include grand rounds, which are updated on a weekly basis, lectures by residents so that your residents can learn how to initiate a lecture, surgical videos, and discussion forums for students. These are further aspects of University of Utah. Then we have a website called irounds.org, which is a useful tool to learn how to present grand round cases or how to present cases, short cases and long cases in the exams. This has case reports, tutorials as to how to initiate preparation for a case presentation, atlas from where you can take pictures and videos which you can incorporate or your residents can incorporate in their lectures without any copyright issue. University of Columbia also runs a digital reference in ophthalmology website, which has very useful information. Mass Eye and Ear and on University of Michigan also have websites. This is from University of Michigan. It's called Eyes Have It. And there is a supercharged website that is iguru.org, which is a collaboration between UCLA, Doheny, Arvind, Wilsai, and Mass Eye and Ear. So it's a very useful resource. Currently slightly slower in being updated, but it is potentially a very useful site because it's a collaborative effort between some of the greatest institutes in the world. Orbis is a flying hospital. Orbis is a great useful tool. It has lectures, surgical videos, quizzes, which are very interesting quizzes, textbooks and manuals as well, and they have several subtopics that are listed. It also runs a discussion forum. Orbis website is quite updated, and it is updated on a monthly basis. Now, if somebody is interested in very special aspects such as ophthalmic pathology, which is a dying art, in fact, there are not many ophthalmic pathologists left in the country and the world because these are, I think, orphan subjects which are being dismantled. There is nothing so much that's happening in the field of ophthalmic pathology in terms of teaching. But it's a very useful resource. All these slides, useful slides related to ophthalmic pathology can be found here. Then we have neuro-ophthalmology website, we have image banks, and closer home we have eOphta, which is run by Partha Pratindatta Majumdar, who is a faculty at Shankanetralaya. If you want question banks of last 10 DNB exams or 20 DNB exams or last 10 MS exams conducted by Rajiv Gandhi University of Health Sciences, you have all that in this website. So residents able to do exam-oriented preparations by going through some of the resources on this eOphta website. AIOS has several aspects which will be addressed in the due course in the next few sessions. But what Dr. Basak has envisioned is AIOS library, which is going to be an e-library, online library, which he is going to talk about. And we also plan to have AIOS virtual university over a period of time. AIOS ebook is already up. GuruSangam we are running, and ARC and IGO also run several portals. In fact, if you go to IGO, which Vanti may be talking about later, we have all the issues of IGO online currently from the first issue to the latest issue, and IGO videos is also online. Going to sources by American Academy of Ophthalmology, we are concerned with ONE network, which was being offered free of charge to Indian ophthalmologists earlier. Now they have a change in policy. So most of the journals are not available currently, and they will go offline very soon. So we are stepping up by creating our own digital library or e-library on behalf of AIOS, where all these journals will be offered in the near future with Dr. Basak's initiative. ONE network otherwise will continue to offer all the other educational content, which are case reports. Journals are of course not available, but then they have other resources which are going to be available, which will be continued to be offered. ICO is mainly an educational channel for teachers. ICO members societies have several symposia which are online. ICO also offers journals from their member societies. In fact, these are journals which are freely available on the ICO website. So there are several resources to obtain digital journals. And this is iplanet.com, which is an Indian initiative from Sun Pharma, which is being transitioned into an app-based access now, which also has offers for several journals. Those of whom we have iFocus Online, which is actually following the AIS curriculum from topic by topic. We have already curated 486 episodes. We have 29,700 subscribers and over 3 million views, which over the next few months, we're going to complete the curriculum in one round. And of course, iFocus 2.0 will start thereafter, which will be by obviously very consummate teachers. These are some of the lectures on iFocus Online, which is available freely on YouTube with several thousand accesses, as you can see, on a daily basis. Auro Shiksha is by Aravind, which mainly concentrates on technical training. In fact, your paramedical personnel, optometrists, and technicians can be trained using some of the resources on Auro Shiksha, which is Aravind. initiative. LVPI has their own website and they offer online access to their grand rounds. Apart from that, we have podcasts, Google, Apple, and Spotify, etc. Podcasts are not draining on your visual resources. You can actually hear these while driving or while you're relaxing. You just put on the headphones and listen to these lectures, which are from very useful resources. This is ophthalmology off the grid. You can use iTube for listening to this podcast, and we can also use Apple Pod System. Essence Snippets from Shankanetralaya has also started podcast. We have several apps as well. My Anatomy, iTube, iGrader, Opto Questions, and AO apps are useful. For surgical skill training, iTube is a very good resource. iTube is a simulated version of YouTube specializing on ophthalmic videos. You can see how clear these videos are, and every step is described by a trainer surgeon. Very vivid, very clear, extremely clear concepts. And we have cataract coach by Uday Devgan. We have oculoplasty videos. These are the oculoplasty video repository. We have this very useful website called Naritas, which is run by Mass India, which is a cataract simulator actually, online cataract simulator website, where the resident practices step. The selection of an action is on the left side menu. And if you do a wrong step, what just happened is the one which will tell you actually what step did you go wrong. How should I do better is something that can tell you as to how you would be able to improve that particular step. And then you can explore this topic further by going on to trainer curated videos. So this is a very useful resource that is coming up, Cataract Master by Mass India. And we have other simulated surgery websites also, remote surgical simulation by mentors, and iMaster program by AIS also aims at surgical training. Cataract surgery video channels, many simulated surgeries, simulation in resident education. There are many websites that are coming up on AO or other resources on simulation. So in summary, internet is unbound and unlimited, offers many resources, but what is important is to go to a particular website or a resource which is well curated, which is well reputed, and at the same time gives reliable information, not going to explore random websites which give you a lot of information but may not be reliable. Thank you so much.
Dr. Honavar, can I make a comment? So government has started this program, One Nation, One Subscription, launched on 1st January. Yes, sir. So all possible, they are tie-ups with all possible big publishers, and it's online. Only thing is that your respective libraries have to get enrolled in that program. It's free of cost, and it's done through IP. So the IPs of the institutions are locked and mated to the system, and all journals, all these journal websites which Dr. Santosh was highlighting, they can be bypassed and all journals can be accessed as of now. So I think especially from I'm 100% sure that all government colleges are entitled for it. Private colleges, I am not sure at the moment, but if any of you are from government colleges, on Google and it will take you to the slide as of now.
Tushar, even private colleges are entitled. They have to register on the portal.
Yeah, I'm not sure about that, but government I am.
Yeah, in fact, we are trying to register AIs through EarnIt, but seems difficult at this point in time.
Maybe it's a initial rush because it was just launched a couple of months back, but it's live.
Yeah.
And every every
I think this generation is very lucky, you know. And when I was a postgraduate in RP Center, so I was given the topic of leukocyte migration test in uveitis. And Professor Madan Mohan was my guide. And then I had to look for the references. There was only one National Medical Library. So I used to go every day to National Medical Library and fish out all the literature pertaining to this leukocyte migration test and immunology in uveitis and so on and so forth. So those days and now you have so many access website and on the different digital platform. I think this is something really great. I'm also using it, and I think that's a great thing to happen.
So I think Santosh, Professor Kirti is going to be there. Santosh? Later, okay. Yeah, so we close the session with one word from Professor Azad. Professor Azad has taken up academics at a very rural hospital as a very high volume hospital. And, I think it will be good to understand from him in a nutshell that how he wants to implement academics in a very, very high volume eye hospital.
I think it's a very challenging job. The problem is that is a high volume surgical hospital. The hospital has 700 eye beds, standalone eye hospital. Can you imagine? And then the hospital is doing more than 1 lakh surgery every year. Now that there are surgeons who are doing 40 cataract in a day. And now I have to put the things on track for the academics. The mindset is different. The guys are coming, they are operating. If those who are operating 40, 60 cases, next day is not coming. Maybe he may not come for 2 days more. So like that kind of system is there. But then there's a lot of material. You can do bloody AI. You can do a lot of these, training programs, like fellowship programs. Somebody wants to do cataract. Bloody come and do 700, 800 retinal surgeries in a year. Can you imagine? So that kind of material is there. So much of teaching material is available there. So I'm trying to put things on track. We are also getting DNB. Hopefully, I think maybe another 2-3 months, we'll get the, DNB seats. And we have started the program. And CMEs, we are first CME since I am in retina. So we had a retina CME. Now we are the next CME. Will be on glaucoma and neuro-ophthalmology. Next will be so on and so forth. So that is planned. So all of you, if anybody is interested, you can come there and see for yourself. Visit the hospital, see the things, the kind of facility which is available there.
Thank you, sir. But sir didn't mention the name of the hospital. It's called Akhand Jyoti Eye Hospital, 40 kilometers from Patna. It's a phenomenal place, something like Sadhguru Eye Hospital in Chitrakoot. It's really worth going and seeing.
I thank the chairperson of the previous session, Dr. Partha Biswas, and the expert panel. I request the next panel to take over. Chairperson will be Dr. Samar Basak, Dr. Basak. And expert panel will be Dr. Manoj Mathur, Namrata Sharma, Professor Pradeep Sharma, and Dr. Preeti Kapadia.
First of all, I like to thank the president and the secretary of All India Ophthalmological Society, because to take up this issue, GuruSangam. As I told you, we did this way back with the help of the government. When I was advisor to the government of India, we had a program, training of trainers. We had, we went to Chandigarh, we went to JSS Mysore. There's a one, faculty from JSS Mysore is here. We went to Patna, we went to Lucknow, we went to Bhopal, so on and so forth. So that is possible, provided somebody, from RP Center or some big institutes, they go and approach them. That is not difficult. And then moreover, in private medical colleges, the AS can take up this initiative, and they can go there and, you know, kind of, as I told you, the National Academy of Medical Science is not a government body. So National Academy of Medical Science, they have a program like Professor Emeritus and visiting professor. So that is possible. Now coming to the topic, this touch the teach. I don't know whose mind was, you know, behind this topic. And when this topic was given to me, I was, you know, remembering Partha, because Partha had given me a topic like science of ophthalmology. And that was, I think, Professor Badrinath's oration in All India Ophthalmological Society. So this is, you know, something like out of box thinking. And when I think it is Santos's brainchild, if this does the teach. Just to teach. So just to teach, you know, it gives you. इसको आगे करो यार. हाँ, बस ठीक है. Just to teach, you know, is something came to my mind, like, you know, Midas touch. You know Midas touch? There was a Greek king, his name was Midas. So whatever he will touch become a gold. And then it came to my mind, in the Bible, there is a reference that Jesus, when he touched the leper, he became all right. In our, you know, Ramayana, Sita was born when Raja Janak was plowing the field, and she came from the earth. So this gave me an idea that this is a kind of a, you know, energy transfer. The teacher is transferring the energy. This is the philosophical side of this topic, touch to teach. Basically, it is active interaction, like we are having active interaction today. It's not that monologue I'm saying and everybody is just listening to me. It is a two-way process. And the other thing here is that when you touch to teach, the person who is teaching you, or the group of people whom you are teaching, should appreciate the teacher. बोलते हैं ना, गुरुर ब्रह्मा गुरुर विष्णु गुरुर देवो महेश्वर गुरु साक्षात परम ब्रह्म तस्मै श्री गुरुवे नमः. Means the Guru is Brahma, Guru is Vishnu, Guru is Mahesh, all the three, and we should, you know, respect them. Sorry. So the concept is of this particular topic is engaging with knowledge, respecting the gurus, and the philosophical side I have just now told you. Somebody was talking about the teaching, you know, that in the colleges or in the institution, you know, the teachers, it is their job to teach. And very rightly said. So who is a good teacher? Who is a good teacher? A good teacher who has a passion for teaching. And he has empathy. Not that he thinks he is a teacher, so he is the Lord and he is the boss. No, he is not. He should have the empathy for the students. Adaptability. By adaptability, I mean that he should be adaptable to the audience. अक्सर ऐसा होता है कि you are going to speak to some student, PG student, and you are talking about the high level, you know, of the, you know, the new researches and all that. So that is the adaptability. And communication skill. Communication skill is very important. And then when you teach, you should try to irritate the gray matter of the audience or the student. That is very important. And then he himself should lead by example. वो कहेगा अरे ऐसा टीचर है ये तो खुद ही जो इधर उधर भटकता रहता है तो ये पढ़ाएगा क्या? So you have to lead by example. And then you have to build relationship. And then you have to yourself be a lifelong learner. Nobody can say ki I know everything. And with the changing world, you know, I just now Santosh presented you that so many things are available in the internet. And I told you when we were a student, what was the situation. So if you upgrade yourself, you will be able to deliver better. And the audience who is sitting there, they'll be able to get more. Last but not the least is the self-assessment of the teacher. A teacher should always self-assess. Now we will deal this in detail. Passion for teaching does not mean that you just come, usme dekh liya, you have read the textbook, you have come in the classroom and you have vomited there. That is not the passion for teaching. And I always say that leaders and the teachers, they are born. You can't make teachers and you can't make leaders. They say ना कि वो जो है उसका बेटा था वो लीडर हो गया. अरे भाई क्या करेगा? उसके जीन में leadership है. So if that is there, you know, that is called passion. Passion is that you, when you are teaching, you know what you are teaching, and then you have also in mind that what I am teaching, that the audience should, you know, get it, and then go from here. So one should be genuinely excited about sharing the knowledge. I know something I want to share. Just now we heard, no? In fact, earlier also we used to hear a few postgraduate will come from, like in RP Center. The day I reached RP Center, everything was open. Microscope was tha, wo jo Hochstreit ka sit lamp tha. Those days you can imagine Hochstreit sit lamp. And everything was open. It was not like, you know, the only seniors are doing and juniors are not doing. So that is called sharing of knowledge, sharing of hands-on skills, sharing of theoretical skills, sharing on communication skills. We used to have the journal club. We used to have the, you know, the seminar, symposia. We used to have group discussions. So that is called sharing of knowledge. So that is very important for a good teacher and student friendly. Like, you know, whenever I go, no, I always keep in my mind ki, like, you know, I go, you go as an examiner. So when you go as an examiner, then you ask questions. Then I start thinking in my mind, when I was student and the examiner was asking me questions, how I was feeling at that time. So I put myself in the position of the student. So I am a student and he is the examiner. So this is called, you know, empathy with the student. And this is called the friendliness, you know. So you have to develop, and then only you will have to have the trust of the student. The student trust is also very important. As you have trust on the student should also have trust on you. And adaptability. As I told you earlier, adaptability means you have to adaptable according to the audience which you have. If you are like, you know, people are called for some, you know, teaching session, और वो क्या करते हैं कि 25 अपना PPT उठा लिया, जो किसी कॉन्फ्रेंस में, इंटरनेशनल कॉन्फ्रेंस में प्रेजेंट किया, उसको लाके वहां प्रेजेंट कर. So that is not adaptability. No, adaptability is what you want to, like, you know, when I was given this topic, I started thinking in my mind, what should I say? If I talk about ROP here, it will be useless. Although it may be useful some, you know, for some people. But then, you know, this is not the kind of audience, this is not the kind of topic which has been allotted to me. I should do justice with the topic, as I am doing justice with Santosh and Samar. So that is very important. And then strong communication skill. So who has the best communication skill at that point, at this time of time in India? Modi ji. Whatever he speaks, I am not talking about the content. Listen to me. I am not talking about the content, but his delivery. How he speaks. And then straight goes into the gray matter of the audience. So that is called communication skill. And communication skill also involves open discussion. We should be allowed to openly discuss. What is your opinion? Please tell me. So that is very important. And as I told you, if you are saying something, it should go into the brain of the audience. It should irritate the gray matter. The gray matter थोड़ा सा उसको पता चले कि ये आदमी क्या बोल रहा है. What is saying? What is his concept? What is his philosophy? What is his academic? What is the background of this guy who is speaking? That is very important. Then only you will receive. Then you will think that ye bol raha, whatever this guy is saying is correct. We should listen to him. But if you have something else in mind, so you will not understand the concept. And then lead by example. As I told you, you have to be yourself a straight person, not straight, you know, in your physical structure, but straight in your thinking, straight in your delivery, straight in your mind about the particular subject, and straight in, you know, letting the content go directly into your brain. That is the straightness. And himself should be honest and should be upright. By honesty, I mean not the honesty in, you know, terms of money. But by honesty, I mean whatever he is delivering, he is honest to himself. What I'm saying is good for the people who are there. That is called honesty. So that is very important. And build the relationship. By this, I mean those of you who have studied in the English school, the missionary school. हम तो missionary school में नहीं पढ़ा. I read in the government school, Pidha wala, you know Pidha. So I read in Pidha wala school, but nevertheless, my younger brother, they studied in English school. So in English school, the principal knows most of the boys or the girls' name. They'll call them by like Radhika, like Vanati, like Santosh. The principal of the school, whether she or he. So that is called the relationship with the student. You know, if you tell them, call them by name, no, they know ownership is there. Like he's my teacher. He's my father-like figure. So that kind of relationship is developed. And that relationship, you know, remains in your mind forever. Even now, those who have studied in English school, they say, oh, Father Murphy was there. Or Madam Stella was there. So that kind of system. And this thing existed in our, you know, culture also, Gurukul system. Now the Gurukul system is not there. But Gurukul system was something like that only. That you go, kind of a boarding school. That you go to the boarding school, you stay there, the teacher knows you, you know the teacher very well, you know his daily course, and he knows you so well. So that is called develop a, a relationship. And as I told you earlier, that teaching is a lifelong learning. ये नहीं कि आज पढ़ लिया. Like today Santosh made a presentation. I learned a lot of things. I did not know so many websites and so many digital platforms are available. I was amazed to know. And when Tushar told me that with one nation and one this thing, you can get access to all the digital platform, especially in ophthalmology, this was a knowledge to me. So that is called updating of your knowledge. But for updating knowledge, one thing is very important. What is important? Important is keep your brain open. If you keep your brain closed, no, I know everything. Oh, no, I don't need this thing. So that is not possible. Then you cannot update your knowledge. Nobody on earth can say, I know everything. And that is the reason of जो हम लोग हिंदी में बोलते हैं अहंकार. So that is because of that. I know everything. I don't need anybody's suggestion. That is not true. And there's self-assessment. And what do I mean by self-assessment? A good teacher is the one who self-assesses himself. Now, after talking to all of you, I'll go, when I'm going back in the car, I will think. I tell you, from the very beginning, from when I used to teach undergraduate, postgraduate, I used to think what I have not delivered to them. If you assess yourself, then you understand, that where you are, how much you delivered, whether it was good for you and good for them or not. So these things are very important, self-assessment. To have your own feedback. Of course, student feedback will be there. Student will talk among themselves. अरे ये क्या था यार, क्या बोल के चला गया ये? Subject कुछ और था, बोल दिया कुछ और. तो that thing, why you let it, the students to make assessment about you. You assess yourself. And I'm sure I'll tell you, if you make assessment yourself, you will be able to know what you have delivered and what you have not delivered. Many a times I know myself. So feedback from self, of course, from peers. Peers are sitting here. And the student, the audience is here. They will all rate me, whether I have done the job or not. So that is very important. So who is a good teacher? A good teacher is someone who does more than just deliver information. They inspire, they challenge, and they guide students towards, audience here, towards deeper understanding and the personal growth. It's very important. Inspire, challenge, and guide. This I will not read. So thank you for your kind attention. Is there any? I think I was ample clear. So if there is anything, we can definitely talk about.
Thank you, Dr. Azad, for that wonderful exposition. You really inspired and you really tried to teach, not the teach. Like you put forward the communication, the skill aspect very aptly. And like the main aim of any speaker is to inculcate into the audience so that the audience picks up at least 50 to 60% of what the speaker speaks. And that is a real success. Thank you very much for that, Dr. Partha.
Sentence, a good teacher
ಟೆಂತ್ ಥರ್ಡ್ ಪಾರ್ಟಿ ನಿಂಗೆ ಕಳಿಸುವಾಗಿಲ್ವಾ? ಹ್ಞೂ ಎಂತ ನಾನೇ ಓಪನ್ ಮಾಡಬೇಕು.
to this. I think we have to support the younger generation. Today, whatever program we are doing, like we have recently referendum. So unless we have younger generation with us, this will never be a successful program in future. So how to get these people to respect AI? These are things where we give them something to these people. We'll help you this, we'll help you in this direction. They'll all come. And every year we have 2,500 people, doing these. Imagine in next 5 years, there'll be 10,000 people. And now, and in 10 years, they'll be the largest group.
But the main point is only we are getting 1,400 to 1,500 annual membership in the iOS headquarters. That's the gap of
1,000, I think there is no importance of,
many states do not have this policy of CME credit and conferences, get a certificate from AIS presentation or your attendance certificate. Otherwise, you will not get, cannot enter into the exam. These are not their mission. They are escaping.
Many institutions, I think it is compulsory to have now presentations by these students. Scientific presentations, or it may be a poster, it may be, yes. Do we have Kudlu there? Yeah, he's there.
Yes, sir. Sir. Good afternoon, sir. I'm so sorry.
We can't hear you.
Sir, sir, can you hear me, sir? Hello, sir.
There's a request from the house, people have to catch flights. So
Yes, sir.
presenters might, reduce their presentation to 7 to 8 minutes so that we can have, this.
Sir,
Could
can
do
you
only
hear?
7 minutes for you.
Sir,
Your
can
voice
you-
is not coming.
Sir, mine is audio is on, sir. Audio is on.
Audio.
Sir, audio is on, sir. Can you hear me?
Audio.
Sir, can you hear me?
Put on your audio.
Sir, audio on, sir. Sir,
No, we can't hear
Sir.
you. We can't.
sir,
It's not getting on.
sir, my audio is on, sir. My side it's on. Sir. Share. Sir.
Dr. Kuddu, can you increase your volume? We can't hear
Sir,
you.
increase.
Oh,
Sir, it is increased to full, sir. 100%, sir. Increased to full 100%, sir.
I think number three, you can.
Sir, can you hear me?
It's not getting turned.
We can just send the slides.
Yes.
You can read.
Sir. Sir, can you hear me? Sir? Can you hear me, sir? Sir, there is some problem in the AOS. Sir? Can you hear me, sir?
मैं कर रहा हूँ.
Sir, my sound is on, sir. My sound is on. Yes. Sir, can you hear me, sir?
1 minute.
Okay.
Yeah, speak.
Sir, my speaker is on in the mobile. I am talking on my system, sir. Thank you so much. Thank you so much.
They're all there with you.
Yes, sir. Sir, I am talking on education initiative by AS proceedings.
Yeah.
KP,
Sir.
the only request from the house is
Ah.
people have flights.
Sir, I will finish 5 minutes, sir. I will finish 5 minutes.
Wonderful.
Sir.
Everybody is tapping for you right away.
Yes, sir. I am so sorry. Sir, see, as we all know that our society is the largest society in the world. I think what is our goal? To train and educate the ophthalmologists to improve the eye care in India. So, yeah, basically our initiatives focus on teaching the latest surgical technique, sharing the clinical research and innovation, and also providing the platform to learn from experts. So what is my job proceeding? Basically, detailed documentation of the conference conducted by our All India Ophthalmological Society, especially presentation, research paper, symposium. Also, we cover every aspect in the subspecialty in ophthalmology. So, what is the importance of AS proceeding? Especially, it acts as a reference for the ophthalmologist, also shares the best practice for latest surgical techniques, and also serves as a valuable learning resource for the young ophthalmologist. So what's our vision? To advance ophthalmic education and improve patient care in India, to provide a continuous professional development opportunities for ophthalmologists and the foster excellence in the ophthalmic research and practice. So the key benefits is especially education resource that provides the repository of knowledge for ophthalmologists, continuous learning, especially documentation. We document everything that captures the cutting edge research and also innovation in the eye care. Especially it bridges the practice in India with a global advancement that helps especially for young ophthalmologists to improve their clinical and the surgical practice. This is how it works. So once you go to the AS website, then you have to open the proceedings of AS 2024. Now you go to the page. So there is a page for a desk. Now I want to know what's happening in the, suppose I want to go for a Kochi conference 2023, then it will open proceedings. Then you will see instruction course, free paper, e-posters, physical posters, proceeding books also. You can open film festival and also invited session and Hyde Park. Once this, if you know, suppose I want to know what happened in Kochi conference, especially what and all the best topics on retinal detachment. So once you type the retinal detachment, from free paper till the symposium, you will open everything in retinal detachment. So you will get a different what and all there. Suppose if you are in the talks on pasplanectomy, multiple treatment on retinal detachment, anything you can open. Once this is done, then suppose someone wants to go to open this. Once you open, then straight away, you even if you want to see the abstract, you will see the abstract. Then if you want to see the video also, just click in, then you will start seeing the video of their presentation. Like this is a video of, then you can see the case history, the whole detail, whatever their presentation in the YouTube, you could able to see. So suppose this is the second one. I'm just trying to rush in fast because Partha sir told me to do it fast. Suppose if I want to open midterm conference, so again I want to see, okay, in midterm conference, what and all the topic is on retinal detachment. Again, I can really search on retinal detachment. Then I can compare what and all the best topics. Suppose Sir Lalit Verma sir is sitting there. Oh, then I can just even I can type Dr. Lalit Verma talks for retinal detachment. Then on name itself, you will open what and all Professor Lalit Verma spoke on retinal detachment. Or cornea, what and all cornea, Basak sir spoke. Or whatever Santosh sir spoke on the oculoplasty, or even Titial sir also. So you will get everything in one shot. So we made so friendly for all our viewers so that they'll be keep updating their knowledge. So next. So this is how, see, if you see every day 5 p.m. we send the mail, and my proceeding opening rate is almost around 21.6%, which is something I feel very good for everybody. So this is how the mail comes. Then you can click that, then you can straight away go for the video. Next. So this is how, see, this is a talk from Professor Titial. You can directly click on that. Straight away it go to the video and go for the presentation straight away. So you can hear everything. So we are trying to requesting the audiovisual people to record it properly, so that Partha sir also last time told about this. So coming to the dynamic ebook, this is one of the initiative from my guru Harbans Lal sir. what is our mission? To advance ophthalmology education in India and innovative tools and resources. What exactly it is? It is a digital book updated on real time. So interactive multimedia features like video, images, and case studies also can be seen. Especially, it accesses the latest guidelines and protocols in ophthalmology. So this how, see, you can download this. You can see here a dynamic ebook. Once you open, you will see this first page. Then if you want, this is the page. You can see everything from optics, cataract, retina, EVS, squint, neuro-ophthalmology, and ocular oncology. Once if you see, suppose if you want, then you can go for search for any of the topic: lasers in retina, diabetic retinopathy, diabetic macular edema, RD, secondary ear. Different topics are there. Suppose once you see this, suppose someone wants to see, suppose if they want to see surgical, you can go for the video also, then can scroll. If you want to see the video also, you can see, or different topics in retinal detachment also you can see. Once if you see, then there is a one in the page also. I'm just coming now. Page, there is a one special link that even if you want to suggest, if you want, sorry, so I am hurrying in. If you want to suggest also, I am just telling, if you want to suggest also, you can send a note that these are my observation, these are my suggestion, and these are my key points. Then it will go to the real author. Then they can connect with the person who has mailed, so that both of them can update their knowledge. These are the advantages. Real-time updates on ophthalmic practice and research. There is an integration. Now we are planning on integration of multimedia elements, especially videos of surgical techniques, interactive case studies, and also animation explaining about the complex procedure. So easy accessibility, compatible with smartphone, any tablet, desktop, for remote learning. So these are the benefits of dynamic ebook: continuous learning, always update with the international standards and advancement, detailed guidelines based on real world AS proceedings and research articles and case studies. Interactive learning especially enables the user to review surgical videos and that attempts quizzes or even browsers visual timeless. This is what we are planning now. Peer collaboration, that options to comment, share insights, or participate in the online discussions. So in the coming days, we'll have a video session. We already started. We are about to do something embedded quizzes, especially these are the tests for self-assessment, and also case simulations, especially hypothetical case scenarios for hand-on problem solving. So in conclusion, it's a revolutionizing learning in ophthalmology, that enhancing accessibility, encouraging continuous interactive education for every ophthalmologist. AI's dynamic ebook are shaping the future of ophthalmology in education. So in conclusion, with AI's proceedings, we learn, we grow, we improve eye care across India and beyond. Thank you. Thank you for the opportunity. I am so sorry that I could not able to travel all the way because of I today opened my 10th center.
Thank you very much, KP. We heard you, we saw you, and it was wonderful. And you've taken the data proceedings to the next level.
Thank you, sir.
Thank you.
Thank you, sir.
One of